What's up, Ninja Nerds? In this video today, we're going to be talking about Cushing's syndrome as well as Cushing's disease. Before we get started though, if you guys like this video, you benefit from it, it makes sense to you, it helps you, please support us. And one of the best ways that you can do that is by hitting that like button, commenting down in the comment section, you already know, subscribe. Also, we got some great notes and illustrations that our Ninja Nerd team has really helped to bring together on our website. I suggest you guys check that out and follow along with me during the lecture. You guys can check that out. I'll put a link down in the description box below. That'll take you to our website. All right, let's start talking about Cushing. So when we talk about Cushing's, the basic kind of pathophysiology, the problem behind this disease is it's just too much cortisol. The cortisol will be way too high, baby. And why is that? So let's go quickly through the pathway of cortisol production. Nothing crazy, but if you guys remember here, we're gonna have up here at this point, the hypothalamus, right? So we're just taking a kind of like a little snapshot picture of the hypothalamus, and then here you have your pituitary. So you have your pituitary, and then here you have your adrenal gland, right? Here you have your adrenal gland. And then you know there's two parts to the adrenal gland. Right here, this is the medulla, and then the outer part here in white is the cortex. Now, there's different types of molecules or hormones that are actually produced that are really important. The hypothalamus at this neuron makes a very specific molecule called CRH, which is referred to as corticotropin releasing hormone. So the hypothalamus makes CRH. CRH comes down and stimulates the anterior pituitary. So this is the anterior pituitary, and this is the posterior pituitary. The anterior pituitary is stimulated by CRH and makes a molecule called ACTH. Okay, so hypothalamus makes CRH, tells the anterior pituitary to make ACTH. The ACTH then comes down here and binds onto these receptors on the adrenal cortex. The adrenal cortex. You know which particular part of the adrenal cortex? If we were to really be specific, there's three parts. There's the zona glomerulosa, the zona fasciculata, and then the zona reticularis. This part here, called the zona fasciculata, is responsible for making a very specific molecule that it pushes into the blood. You know what this molecule is called? It's called cortisol. It's called cortisol. Now, in patients who have Cushing's syndrome, this is an interesting situation where their adrenal gland is the problem, and they're just producing too much cortisol. Maybe there's a tumor there. Maybe there's some hyperplasia there. Whatever it may be, there's a problem where the adrenal gland is the source of high cortisol. Or there's also known as Cushing's disease. And Cushing's disease is that there may be way too much ACTH because the anterior pituitary is producing too much of this, or there's somewhere else in the body that's making too much ACTH. That's stimulating, hyperstimulating the adrenal cortex to make more cortisol. But this is the problem, my friends, with Cushing's, is that in Cushing's there's high levels of cortisol. Now the question then comes, okay, there's high levels of cortisol, what does that do to the body? How will the patient actually clinically present? And that's a great question. So the first thing that I want you to remember is when cortisol is really high in the blood, it can affect many different systems within our body. To really break it down to the most simplistic and important components here, let's talk first about how it affects the sympathetic nervous system. You know what it actually does? So you know here you have your autonomic nervous system, usually in the lateral parts, these kind of like lateral ganglion, the lateral gray horns. These generally have a lot of ability to innervate a lot of viscera. All right, so you have your autonomic nervous system, particularly the sympathetic nervous system. What cortisol has been shown to do is that high cortisol has been shown to kind of increase the activity or the sensitivity. So let's say activity and sensitivity of the sympathetic nervous system. And so why is that important? Okay, if I have an increase, let's say that I actually release from these portions, these like little motor neurons area, I release something like norepinephrine. So I can release things like norepinephrine. You know what norepinephrine does? Norepinephrine loves to bind onto these adrenergic receptors on our heart, very powerfully. So let's say here on our heart, we have these receptors here called beta-1 adrenergic receptors. They're on the actual contractile portion of the heart. And then you see these like black cells here that are kind of right here, the SA node, the AV node, the bundle of His, the bundle branches. These also are beta-1 adrenergic receptors. These are very special. You want to know why? Because when norepinephrine binds onto these beta-1 adrenergic receptors, it does two particular things. One is when you stimulate the beta-1 adrenergic receptors, you increase the heart rate. That's one thing, especially for these nodal cells. So I'll have fire action potentials quickly through the AV node, all through the bundle of His, the bundle branches. On top of that, if I bind to the contractile portion, I will also increase my stroke volume. I'll contract more. And if I contract more, I'll push more blood out of the heart. Collectively, what this will do is this will increase cardiac output. And that can do what? Increase blood pressure. There's another receptor. So we have the beta-1 adrenergic receptors here that are on the conductive system. Just so we know, we have beta-1 adrenergic receptors that are on the conducting system. And we also have beta-1 adrenergic receptors that are on the actual contractile portion of the heart. They increase heart rate, stroke volume, and cardiac output. But there's also alpha-1 adrenergic receptors that are present on your blood vessels, your arteries. And when norepinephrine binds onto these, it squeezes the life out of them. And you know what that does? That increases the vasoconstrictive response, which helps to increase your blood pressure. So it also hyperstimulates your alpha-1 adrenergic receptors, which helps to increase your systemic vascular resistance. And this increases your blood pressure. You see how all of these things cause a pretty significant problem here, is that you increase the blood pressure for the patient. Now, what we know is cortisol normally increases the sensitivity and the activity of the sympathetic nervous system. But really what I want you to know is it increases the upregulation of these receptors. So you increase the number of beta-1 receptors and alpha-1 receptors, and you increase the actual sensitivity to them. So when norepinephrine binds to these, it produces a response. When it's high levels of cortisol, it's an amplified response. So that is the big thing that I want you to remember, that high cortisol will precipitate in this kind of balance between the sympathetic nervous system and the cardiovascular system. Is that it increases the activity and the sensitivity of the sympathetic nervous system. How? By increasing the number of beta-1 and alpha-1 adrenergic receptors and increasing the response whenever norepinephrine binds onto them. It has an amplified response, and you get this particular effect. Now, it's really, really important to remember this, because when these patients have very high blood pressure, it's very interesting because they are refractory to a lot of standard therapies. So I want to write this one down here, that this blood pressure that's really, really high is very important because it can produce something called secondary hypertension. So I really, really don't want you guys to forget this, is that it can produce something called secondary hypertension. So basically they have very high blood pressure, and their blood pressure doesn't typically respond to 1, 2, sometimes 3 antihypertensives. So that's really important to remember in the clinical vignette, is you have a patient coming with high blood pressure, still having high blood pressure despite multiple antihypertensives. Okay, what else can high cortisol do? You know what else this son of a gun can do? High cortisol is a son of a gun to our immune system. So you know neutrophils. Neutrophils are supposed to do something called margination. So let's say, for example, there's a pathogen out here. Here's my pathogen. Here's my pathogen. I come in, to an infection. I have an infection of some sort. Pathogen in my body. What happens is neutrophils should do something called margination, where they slide along the vessel wall and then they squeeze through the vessel through what's called diapedesis. Right? So they kind of move through, they do this thing called margination, where they roll along the blood vessel edge and then they squeeze through the blood vessel so that they can get out here and fight off this bacteria, right? They want to destroy that bacteria. But you know what cortisol does? High levels of cortisol will actually suppress the margination response. It inhibits the margination response. So they can't marginate. They can't stick to the blood vessel wall and then squeeze through to fight off the bacteria. Oh, that's not good. So that's one thing, is it inhibits neutrophil margination. So let's write that down. One thing is it inhibits neutrophil margination. And that's going to actually produce two things. One is it can actually make your white blood cell count higher, but it inhibits you from being able to fight off infections now. The other thing is that high cortisol is a son of a gun, man. High cortisol can also suppress your T cell response. You know your T cells? These guys, these good, ones who are supposed to help with immunity, they're supposed to proliferate. So they naturally can go through proliferative responses. You're going to inhibit their T cell proliferation. You will inhibit T cell proliferation. And these are supposed to be important because they help to be able to allow for you to generate proper immune responses. Now you can't generate a proper immune response. Plasma cells. These are supposed to produce antibodies. You know what cortisol does? Inhibits antibody production. So it can inhibit antibody production. Oh no, this is not good. Because I have an inability to generate an immune response to fight off this bacteria. I now don't have the antibodies to fight off this bacteria, and I don't have neutrophils that can come and eat the bacteria. So now I'm at high risk for infections. That is the problem with this, is that these patients are high risk for infections. You know which ones are the worst one? Fungal infections, especially. Let's actually write that down. They're high risk for fungal infections, especially. But any kind of infections in general, they're very high risk for because you've had an immunosuppressive effect. That's why you ever notice whenever you're really, really stressed in life, sometimes high stressor situations, getting ready to prepare for an exam like you're probably preparing right now, you ever notice that sometimes you get really sick? This is one of the reasons. The cortisol production is kind of a long-term stress response. So whenever you get really acutely stressed, your sympathetic nervous system becomes activated, but that long-term stress response that continues on for your daily life struggles is the cortisol response. And so that's why patients who are highly stressed, guess what? They can have hypertension and they can also have high risk for infections. So that's a really, really big thing to remember. Okay, my friends, there's way more, but we got to come over here and talk about them. All right, my friends, so we talked about how cortisol, high levels, increase sympathetic effects, particularly by increasing activity and the sensitivity of it on the heart. We also suppress the immune system, so now we're at really high risk for infections. That's not it. It has a very profound effect on your metabolic and endocrine system as well. So, you know, cortisol, whenever there's really high levels of cortisol, what it does is it actually acts on the liver. And it loves to bind onto the liver. And when it binds onto the liver, it actually provokes two particular processes in the liver. One is it does something called gluconeogenesis. You guys know what gluconeogenesis is? I know you do. It's basically where we take things that are non-carbohydrate sources, amino acids, things like glycerol, things like odd-chain fatty acids, lactate, things of that effect, amino acids, and convert them into glucose. Okay? That's one thing. The other thing is it does something called glycogenolysis. So it does two particular effects here. One is it helps to stimulate what's called gluconeogenesis. Gluconeogenesis. This is a really, really important one, guys. Please don't forget this. And it also stimulates something called glycogenolysis, where you break down glycogen into glucose. So the whole point of both of these is that I'm pushing glucose out of the liver cells into the blood. So what's happening to the blood glucose levels? The glucose is shooting through the dang roof. You're getting hyperglycemia, baby. What would hyperglycemia naturally do, though, to the actual pancreas? Naturally, high glucose levels should stimulate the pancreas to produce insulin. Problem is, though, is that now we're going to start trying to produce lots of insulin, and cortisol actually may suppress the insulin production as well. So cortisol might even have the ability to have a kind of suppression of insulin production. So now the glucose levels will continue to be high. And this problem with the high glucose levels is this increases the risk for diabetes mellitus. Oh no, oh no. So high glucose levels, I'm gonna get the diabetes from this too. That's not a good thing. So again, the whole point of this is that these two processes, the glycogenolysis and the gluconeogenesis, will precipitate high glucose levels. High glucose levels should naturally stimulate your pancreas to produce insulin. Right? You should make more insulin, try to shunt the glucose out of the blood and into cells. But cortisol may also suppress insulin production to some degree. So now you continue to have high glucose levels and then end up with an increased risk of diabetes. All right, this is called the diabetogenic effect of cortisol, okay? We can actually write that down. This is called the diabetogenic effect. I wish I was actually making this word up, but this is real. It's real. All right. Next thing has another very profound effect. You would think it's a good thing, but it's actually kind of a bad thing whenever there's super high levels of cortisol. So you got to think about this. Whenever you're stressed, right, your body wants to be able to generate a response. So whenever you're kind of acute stress, your sympathetic nervous system becomes activated and cortisol production becomes activated. You want to push your blood pressure off so you can perfuse your muscles and things like that to run away. You also want to be able to have lots of glucose for your muscles and brain to be able to utilize to run away or deal with stressors. In the same way, we want to have as much fuel for our heart and other organs to, particularly function. So one of the other things that high cortisol will do is it'll bind to the adipose tissue. But whenever the cortisol levels are super high, it actually starts taking cortisol from the extremities. And then what it does is it redistributes it to your central kind of portion of your body. So that's a terrible situation. So it also, high cortisol, so here we're gonna have these cortisol receptors. In reality, just so you guys know, cortisol is a steroid hormone, so it doesn't have extracellular receptors. It has intracellular receptors, but just for the sake of this, high cortisol will bind onto these receptors, and it'll trigger a process. It'll stimulate something called lipolysis. So it'll stimulate lipolysis. Basically what we'll do is we'll take triglycerides that are in the fat tissue and we'll break them down into free fatty acids and glycerol. But here is the problem. Not only does it stimulate lipolysis, it stimulates fat redistribution. Redistribution. And this is where it becomes a problem pathologically. So if we have both of these, guess what happens? You break down fats from the periphery. So this is going to cause lipolysis of the, let's say, extremities, just to make it easier. So you're going to break it down from the extremities, the peripheral tissues. And then you're going to fat redistribute. You're going to take this free fatty acids and glycerol and distribute them to the central part of the body. You know what happens? You break down fat tissue in the periphery and send it to the actual central part of the body. The face gets swollen. The abdomen gets all puffy. And then you end up with a buffalo hump in the back of your neck. It's a terrible situation. So there's three things that happen here. One is you get the moon face. Second is you get the buffalo hump. And the third thing is you get significant abdominal obesity. Significant abdominal obesity. And then you get these like thin kind of like extremities, which is really, really sad. But this is super, super important, guys, and I need you guys to remember this. If you see this in a patient, you have to be thinking about the possibility of Cushing syndrome, okay? Okay, so we've got so far with endocrine metabolic, we've talked about high glucose. It's causing lipolysis because if we have to break down lipids, we can get free fatty acids and glycerol to go to the muscles and utilize for energy. But in this case, we're breaking them down and then redistributing them to other areas. That's the problem. The other thing that happens here is for proteins. Again, we want to be able to have as much glucose as possible. So you know whenever you break down fats, you can take some of the odd chain fatty acids, turn that into glucose. That's called gluconeogenesis. Same thing, I can break down proteins in muscles and connective tissue and bone tissue and utilize that for making glucose via gluconeogenesis. So I'm actually going to break down proteins, sadly. So whenever I have high levels of cortisol, it's going to also bind on to multiple different types of cells. So let's say that this is of muscle tissue. Let's say that this is of connective tissue. Let's say that this is of bone tissue for these cells. I'm going to induce an intense proteolysis. And I'm actually going to inhibit the synthesis of a very specific type of protein. I'm going to inhibit collagen synthesis. And this is a real big deal because I'm going to break down proteins that are in muscle, connective tissue, and bone, and I'm going to inhibit collagen synthesis, which is important, especially in connective tissue and bone. Now, what would that look like? If I inhibited protein synthesis, or if I actually broke down proteins and inhibited collagen synthesis, what would that do to the muscles? They would get super weak and thin. So you would end up with a lot of atrophy. And you know where this most commonly affects? The proximal muscles. So your shoulders and your hips, and even in general, like the extremities, they would get really, really small and tiny. So you get atrophy, right? The other thing is for the bone tissue. You know, bone is heavily made of collagen. So we depend upon collagen to give the bone a lot of its strength. And guess what? If you start breaking down the collagen in the bone tissue, oh no, you're going to get the osteopenias. You're going to get osteopenia. So where the bone gets really, really thin, and then you have increased risk of osteoporosis. And then you have increased risk of fractures, my friend. Oh, this is terrible, terrible stuff. So one particular thing here that's really a big deal is that you can induce the risk of osteopenia, osteoporosis, and fractures, and you can also cause atrophy and muscle weakness of the proximal muscles. Here's the big one though. Collagen is very heavy in our dermis. So you know collagen should be very heavy in the dermis. So here's our epidermis, here's gonna be the dermis, which all this blue is collagen. It's supposed to provide a good tensile strength to our skin. right? Helps it to kind of have a thickness kind of appearance, and it really helps with kind of the general integrity of our skin. But now you start decreasing the collagen that's present in the skin. Oh no. You know what's gonna happen? You're gonna have very thin skin. So you're gonna have thin skin. And the problem with this thin skin is that you lose the integrity of the skin. And two particular things happen. One is you can get something called striae. And this is very prevalent in the abdomen area. Oh, it's so bad. It's actually so bad. The other thing is that you have increased risk of something called ecchymosis. Ecchymoses. This is actually a really bad thing where you have a lot of these kind of like a bruising type of appearance on the skin. And then also because the skin is so thin and you don't have a lot of the collagen to repair it, you have slow wound healing. Doesn't this sound absolutely terrible? Plus you don't have the immune system as well. So this is also going to impair the wound healing. So this is a really, really sad situation, and this is super, super important. So if I ever have a patient who comes in and they have any type of this fat redistribution features, and they have a lot of thin skin with abdominal striae, ecchymosis, slow wound healing, these are really two big things that trigger me to think about Cushing syndrome. These are really, really big. You can't forget that. All right, so real quick before we move on to the next part of the endocrine system and metabolic effects, I want you guys to take a look at what an actual moon face would look like. So take a look at this real quick. All right, so we saw what that looks like, really, really sad, right? But then we also see another effect of, again, the problem whenever there's the buffalo hump. Take a look at what this looks like. Now, the other thing is that whenever you have a patient who has abdominal obesity and thin skin, it causes this intense abdominal striae. Let's take a look at what that looks like. So you guys have seen some of the really, really big things that are super important to understand when a patient has Cushing syndrome. I can't stress this enough. The next thing, and really quickly we're going to go through this one because it's not as high yield, but whenever a patient has Cushing syndrome, maybe they're producing too much cortisol, right? And again, we talked about, and we're going to go over this in a second here, but when a patient makes too much cortisol, it could be because of the adrenal, or it could be because of the pituitary. But in this situation, let's say it's because of the adrenal. Whenever there's high levels of cortisol, what that does is it inhibits the pituitary from making a very specific type of hormone. So you know your hypothalamus makes something called, so there's hypothalamus here, it makes something called GnRH. Let's actually write that down. GnRH, gonadotropin releasing hormone. And what that's supposed to do is come down here to your anterior pituitary and stimulate the production of FSH and LH, follicle stimulating hormone and luteinizing hormone. Whenever there's high levels of cortisol, it suppresses GnRH production and it suppresses FSH and LH production. If I don't have these and there are low levels of them, I can't stimulate the testes and I can't stimulate the actual female reproductive organs to perform their proper functions. And so in men, this leads to a decrease in libido due to a drop in their testosterone production. And then for the female, it actually affects her ability to control her menstrual cycles, right? So she may have very little menstrual cycle activity, and this is called amenorrhea. So these are some of the big things that you want to remember, especially for the endocrine kind of reproductive effects. So again, I think it's really important to know that for the endocrine metabolic, this is where you see most of the effects here. Diabetes or the diabetogenic effect, because of glycogenolysis and gluconeogenesis. You see a lot of the fat redistribution and lipolytic effects. And then from the proteolysis and decreased collagen synthesis, you see the thin skin, abdominal striae, ecchymosis type of effect, as well as maybe some myopathy and increased risk of fractures. Before we go on to the actual causes of Cushing's, particularly Cushing syndrome and Cushing's disease, I want to talk about just two quick exceptions to Cushing's that you can see. All right, so real quick, we already talked about a lot of the cortisol effects in target organs, right? And we talked about the most important ones. I really highlighted, and I'll highlight it again a little bit later. But there's two quick exceptions that I have to point out because they sometimes come up and they actually make sense. So we talked about how whenever a patient has high cortisol, it's due to two problems. One is the adrenal cortex is the problem. It's the one that's pumping out tons of cortisol, right? It's the problem in this situation, right? So there's an adrenal tumor of some type. The other concept is that there's something going on with the pituitary where it's making too much of something called ACTH, right? So that could be a problem. So there's two reasons of why someone could develop, Cushing's. One is there's high ACTH levels. This is called Cushing's disease, or there's high cortisol production by the actual adrenal regardless of ACTH. This is called Cushing's syndrome, and we'll get into that in just a second. But in Cushing's disease, let's say that the patient is producing way too much ACTH. Not only, yes, can it produce a high level of cortisol, but there's another really, really sad effect where it can produce a lot of what's called androgens. So these are like sex hormones, and especially in females. So I'm actually going to put that this is really particular in females. And one of the problems with this is this can cause things like acne, and it can cause severe hirsutism. Hirsutism. I want to show you guys a picture of what hirsutism would look like in these actual females due to high ACTH production, not only causing high cortisol, but also high androgen production, which produces this type of effect. Take a look. All right, so again, it's really, really important that the reason why this happens, the hirsutism and the acne, it occurs because of this particular problem. High ACTH, which then produces high cortisol and high androgens. It's not due to cortisol being the primary issue. So you would really only see this whenever there's some type of like pituitary tumor. That's the big thing to remember. So you would see this likely in some type of pituitary tumor. And the same effect, whenever you produce lots of ACTH, right, guess what is another hormone that you produce because they're made from the same precursor? So another thing that you can make whenever you're making a lot of ACTH is you make a lot of something called melanocyte stimulating hormone. And that melanocyte stimulating hormone will go and stimulate the melanocytes in your skin. And when you stimulate the melanocytes in your skin, you cause them to produce tons of melanin. So you're gonna have an increase in melanin production. You know what that does to the skin? It makes it super hyperpigmented. And so this produces something called hyperpigmentation, which is another interesting sign. But again, really, really important to remember that you don't see this in Cushing's syndrome. You only see this in Cushing's disease due to a pituitary tumor. So in patients who have Cushing's disease due to a pituitary tumor, they can have all of these effects, except they may also have hirsutism and acne, which we showed a picture of, or hyperpigmentation as well, due to the high ACTH production. Okay, we've really gone heavy, my friends, on the pathophys. So how is high cortisol levels causing these particular clinical features and complications? The next thing that I really want to take some time to talk about is, what are the causes of the high cortisol? So we know that it could be adrenal, and we know that it could be pituitary or something else. Let's actually talk about that a little bit more. So one of the really, really big things is understanding pathophys here. So let's say that here you have something wrong with the adrenal cortex. Maybe there is a tumor of some sort. So sometimes if you have a tumor of the adrenal gland, this could be like an adenoma. Believe it or not, those are very, very common. Or it could be a carcinoma, which would be terrible in that particular situation, but that also can happen. If this is the problem, then it's the reason why you have these massive levels of cortisol in the bloodstream. And that is the problem. It doesn't take much more than that. And this is producing these high levels of cortisol because this tumor has gained the potential to produce massive amounts of cortisol. It's a secretory tumor. And that's why you'll see it more commonly with adenomas. But whenever there's high levels of cortisol due to the adrenal gland, that's one problem. You know what, there's another problem? And believe it or not, it's becoming very, very common nowadays. It's a little bit underreported, but it is very common. Another one is iatrogenic. So maybe it has nothing to do with the adrenal. Maybe it's a patient who is on chronic steroids. They're on chronic steroids. People are on chronic steroids for millions of reasons. One of the most common one is that, for example, maybe they're on it for like an autoimmune disease, right? So maybe they have something like rheumatoid arthritis or SLE or whatever it may be, multiple sclerosis, and they're on a steroid for that particular purpose. That steroid that you give them may have steroid-like properties and act like cortisol. And so that's a really, really important thing because these are corticosteroids, so they have the potential to act like cortisol. And that is really, really, really important. And this can also have a very similar effect. So this is a corticosteroid of some type, maybe something like prednisone or hydrocortisone or whatever it may be. This is going to have very similar types of effects to cortisol. And so there's going to be high levels of this. So they'll still have all of the same effects, because since this can act like cortisol, it'll produce all the similar effects we just talked about above. The big thing here is, if it's high cortisol levels specifically, then we know it's from the adrenal tumor. But if it's these high corticosteroids, the cortisol isn't actually as high, then we know it could be iatrogenic. So some type of exogenous use of for autoimmune disorders of some type. But whenever there's these high levels of these corticosteroids, whether it be the corticosteroid that we're giving or high cortisol levels, you know what these tend to do? These tend to have a very kind of strong negative feedback effect on the pituitary. So whenever you have high cortisol levels, you should tell the pituitary, hey buddy, stop producing ACTH. The cortisol levels are already high. We don't need you to make more ACTH so that you can tell the adrenal cortex to make more cortisol. Stop making ACTH. And so what should happen is you should suppress the ACTH production. So whenever a patient has Cushing syndrome, which is what we would call primary, we would actually kind of give this another name called primary hypercortisolism. So primary hypercortisolism, meaning that the adrenal cortex is the problem here. Then we would think, is it a tumor? Adenoma, likely. Carcinoma, also possible. Or is it iatrogenic? We're giving them something that acts like cortisol. If that's the case, the cortisol level will be high and the ACTH levels will be low. And that's a really, really common sign of Cushing syndrome. Now, the next thing that I want to talk about here is Cushing's disease. Let's talk about Cushing's disease. All right, so the next concept here is if someone has Cushing's disease. So again, we said the reason why a patient can have high cortisol is because the adrenal gland is producing too much of it, or we're giving them a drug that's acting like cortisol, like a corticosteroid. So they're on that for an autoimmune disease. Think about those things. Look in their history. Are they taking a steroid? And the other concept here that's really interesting is with chronic steroid use, you will suppress ACTH production, and the adrenal gland over time, if you're chronically on steroids, the adrenal gland will atrophy and they will actually produce less cortisol over time if they're on that chronically. So it's very, very important to remember that, okay? But that's the causes. High adrenal production or iatrogenic cause from chronic steroid use. The other thing is ACTH is the driver. It's not cortisol production directly from the adrenal cortex, it's ACTH production from the pituitary or somewhere else that's driving cortisol production. So that's a good thing, right? So if there is, in this particular situation, a pituitary tumor. So there's a tumor here and this sucker's just pumping out the ACTH. ACTH levels are through the roof because you have a pituitary, usually a pituitary adenoma. Very, very common, okay? Or you got a huge honking small cell lung cancer. This tends to be one of the most common ectopic sites. There's other ones like pancreatic islet cell tumors or renal cell carcinoma. If you really wanted to add those, you could, but I think the most important one is to remember small cell lung cancer. This also has the ability to produce massive amounts of ACTH. And so we call this ectopic ACTH production, meaning it's coming from a site that doesn't normally produce ACTH. It gains that ability due to a tumor, okay? So it's a pituitary adenoma that's producing ACTH, or it's an ectopic site, like a small cell lung cancer. If you really have the extra memory, pancreatic islet cell tumors, renal cell carcinomas are also other ones. But please don't forget this one. So ACTH levels are through the roof. If ACTH levels are through the roof, then what is it going to do? It's going to go and act on, what we showed up on the above, is that it will act on these ACTH receptors that are present on the adrenal cortex. Do you guys remember which point? The zona fasciculata. And then from here, it should start pumping out massive amounts of cortisol. And the cortisol levels will be high. That is the big thing to think about here. So again, the important concept for Cushing's disease, which is in this kind of situation, an interesting concept here, is that the problem is not from the actual adrenal cortex. It's actually from the pituitary gland. They have an adenoma, or they have an ectopic site of ACTH production, such as a small cell lung cancer, pancreatic islet cell tumor, or renal cell carcinoma that's pumping out ACTH, telling the adrenal cortex to pump out cortisol. Now, Your thought would be, oh, well, I know negative feedback. Negative feedback, if cortisol levels are high, should go back and suppress the pituitary from producing ACTH. Guess what? Pituitary don't care about the high cortisol. It will continue to produce ACTH levels at high amounts. So that's one of the big ways that you can differentiate when you think about that, because we're going to talk about it in a second. Ways of being able to differentiate between Cushing's disease and Cushing's syndrome is what? Well, if the cortisol levels are high, that should be in both of them. But if ACTH levels are high, that means it's a pituitary or ectopic. If ACTH levels are low, that means that the pituitary is intact and there's no ectopic site. That means that they're responding appropriately to high cortisols and negative feedback is suppressing it. And that would be an adrenal or iatrogenic problem. All right, my friends, now that we've gone through the pathophys, the clinical features, the complications, the causes, now we can do is do a strong diagnostic workup. All right, my friends, so we're gonna diagnose a patient who we think has Cushing's, whether it be Cushing's syndrome or Cushing's disease. We'll elucidate that as we go along. But again, I want you to think about this. High cortisol production is causing things like increasing the sympathetic nervous system effect and sensitivity, so high blood pressure. Secondary hypertension is the big thing. Also, don't forget about immune suppression, so having lots of infections, one after another, especially fungal. Don't forget about problems with high glucose levels, so now they got diabetogenic effects. They got fat redistribution, moon face, buffalo hump. They also got really big abdominal obesity. They got also impaired protein problems. So they have increased risk of myopathies of the proximal muscles, fractures, and then big thing, thin skin with ecchymosis and abdominal striae. And then they may also have reproductive issues such as a decreased libido in men and also menstrual irregularities in females. And then if you really wanted to add on that other thing, we could say, oh, okay, what if it was the pituitary that was the problem? It was producing lots of ACTH. That could present with hirsutism and acne, as well as hyperpigmentation due to the increased ACTH production. And then we talked about causes, right? We said it could be an adrenal problem, a chronic iatrogenic problem, or it could be a pituitary tumor or an ectopic site of ACTH production. So how do we figure out all these things? When we have these patients, first thing to do is you have to screen them. So you need at least 2 out of the 3 of these tests that we're going to talk about to be positive. So for these, you need at least 2 of 3 to be positive. So the first one that we actually utilize a lot, and you'll see it in your exams, is the low-dose dexamethasone suppression test. It's a really cool test. So what you do is you give the patient 1 milligram of dexamethasone. So you give them dexamethasone, which is pretty much like it's a corticosteroid, is essentially what it is. It's a corticosteroid. And what you do is you give them the dexamethasone approximately 1 milligram. When you give them the dexamethasone, naturally what it should do in a normal patient is it should suppress ACTH production, okay? It should suppress ACTH production. And then if you suppress ACTH production, you should suppress the adrenal cortex from producing cortisol. So there should be lower levels of cortisol in a normal human being. So what should happen here? Cortisol levels should drop. This would be a normal response to a normal patient who does not have Cushing's. But if they have a pituitary tumor, that's an issue, or they have an adrenal tumor that is the issue, they will not respond to the dexamethasone. They will not be suppressed. And so a patient who actually has Cushing's, so if they have Cushing's, they will not have this response. Their cortisol levels will remain high despite the dexamethasone because the pituitary won't be suppressed by the 1 milligram of dexamethasone. And then guess what? The adrenal cortex don't give a crap about dexamethasone. It doesn't affect it at all. It'll still continue to pump out cortisol. So that is the big thing, is that there will still be elevated cortisol. They will not respond to the dexamethasone being able to suppress the pituitary. It won't be enough to suppress ACTH production, so it'll still be high, still cause the adrenal cortex to still produce high levels of cortisol. And if you give dexamethasone, and if it's not a pituitary problem, they'll produce ACTH, but that won't matter because the adrenal cortex will still continue to pump out cortisol. That is the big problem. So if the cortisol level is high, it's Cushing's. If cortisol level is low, that's a normal response. All right, that's one test. Second test, which I actually really like this one, I think this is another really good one to do, is a urinary cortisol over 24 hours. And basically it's the same kind of concept. You're not doing anything to suppress or stimulate this. What you're doing is you're just taking the normal physiology. And so over 24 hours, what I'm gonna do is I'm gonna collect urine from these patients. So I'll collect their urine, and what I'm gonna actually measure is, I'm going to measure the cortisol levels in their urine. So I just want to know the cortisol levels in the urine, are they high or are they low? Now theoretically, in a normal patient, they shouldn't have high levels of cortisol in their urine. We should have a normal production. But in patients who have hypercortisolism, guess what? Cortisol is secreted into the urine. And so because of that, just think about it normally, guys. If you have a pituitary tumor or you have an ectopic site, they're making lots of ACTH. That's telling the adrenal cortex to make lots of cortisol. This would be Cushing's disease. Or if it's a problem with the adrenal cortex pumping out cortisol, this would be Cushing syndrome. But the cortisol levels will be high. When the cortisol levels are high, guess what? They actually do run through the blood. They get filtered out and they can be excreted, so the cortisol levels will go up. If the cortisol levels in the urine over a 24-hour period are high, this is suggestive of Cushing's. Again, it doesn't tell you which one it is, right? I still don't know, is it due to a ectopic, a pituitary, or an adrenal problem? I just know they got possibly Cushing's. So I can't exclude them possibly having Cushing's. So if this is positive and this is positive, I'm done. I can move on to the next test. But if I don't have these available, I can do one more test. This is also another really good one for some patients who don't have the ability to collect urine over a 24-hour period, which is possible. Same concept. We can just basically take the saliva at night. We generally do it around like 11 p.m., so right before bedtime. What you'll do is you'll take some of the saliva and you'll collect it. Now, cortisol is secreted not only in the urine, but also in other secretions as well. So what I can do is I can measure the cortisol that's present inside of my saliva. And so this is what I would do is I would actually take and look at the actual cortisol present in the saliva. So this is going to be saliva. And I'm going to measure the cortisol levels. If the cortisol levels are high, which is again seen in possibly Cushing syndrome, this would be telling me that again, there is a high ACTH production from the pituitary or from an ectopic site. This is telling the adrenal cortex to produce lots of cortisol, or the adrenal cortex has a tumor that's pumping out lots of cortisol. This is getting into the blood and it's being picked up by these salivary glands and being pushed into the secretions. If the cortisol is elevated, this would be indicative of a possible Cushing's diagnosis. So all I need is, I need 2 out of these 3 tests to be positive if cortisol level is high in the saliva, and usually we do that late at night around 11 p.m., or a 24-hour urine cortisol to be elevated, or them to not be suppressed by 1 milligram of dexamethasone in that particular response. If 2 out of 3 is positive, we go to the next test. All right, so we have a patient, we've screened them, we now have positive 2 out of 3 tests, whether we did a low dose dexamethasone and urinary cortisol, they were both elevated. Okay, I can't exclude Cushing's. But now I don't know if it's Cushing's syndrome or Cushing's disease. In other words, I don't know if it's coming from the adrenal, from an iatrogenic cause, or is it coming from the pituitary ectopic site? How do I determine that? Look at the ACTH level. That'll help me right away. I think this is so cool because if I know the cortisol levels are high from urinary cortisol, salivary cortisol, they don't suppress, I know it's Cushing's. And then if I say ACTH level is low, then it's primary, it's from the adrenal. If the ACTH levels are high, it's from the pituitary or from an ectopic site. It's not hard to imagine, right? So if the problem is that these are the suckers that are producing lots of ACTH, and that's telling the adrenal cortex to produce high levels of cortisol. I know the cortisol level is high because of these tests. If the ACTH levels are high, what does that tell me? That tells me that this is Cushing's this is Cushing's disease, if you will. And this could be due to a pituitary problem, or it could be due to an ectopic problem. If it was the adrenal cortex that was the problem and the cortisol levels were high, what would it do to the ACTH levels? It would inhibit the ACTH levels. And they should subsequently, if I were to kind of draw another arrow here, they would subsequently drop. This would be indicative of Cushing syndrome. This would be indicative of Cushing's syndrome, right? And that could be due to an adrenal mass, like a tumor, or it could be iatrogenic. And oftentimes I can just look at the patient's history and determine, oh, they're on steroids. Okay, that probably is the cause. But I could also do other things to kind of confirm if it's a tumor or not. But you get the point. ACTH levels are low due to cortisol being the primary problem, and it's not the pituitary that's the issue. If the ACTH levels are low, it's Cushing's syndrome. If the ACTH level is high, that's Cushing's disease. That's the big difference there. Okay, so let's say that we've gone through and we've said, okay, I know that it's from this, ACTH levels are high. So let's say that we did this. We did the first screening test, cortisol levels are high. We got Cushing's. Don't know which type. Do the ACTH level. Oh, ACTH levels are high and cortisol's high. It's a secondary cause. In other words, a pituitary or it's an ectopic problem. How do I know if it's the pituitary or the ectopic site? So then that's what this test is really good at. I find it to be very helpful at which secondary cause. Which secondary cause is it? So what I can do is I'm going to amp up my dexamethasone dosage to a dose that actually has the capability to suppress ACTH production. And a dose that has been found to have the capability to suppress ACTH production from the pituitary is 8 milligrams. So 8 milligram push of this dexamethasone. When this is actually present, if a patient has this pituitary tumor or the small cell lung carcinoma, what we want to know is which one is suppressed by the 8 milligrams of dexamethasone. In this particular situation, if it's a pituitary tumor versus a ectopic site, like a small cell lung cancer, as we gave an example of. In this situation, it will not suppress. This will continue to produce ACTH. It can't be suppressed. So you know how you'd want this one to inhibit it? We would say it like this. We would actually say, oh, you would think it would inhibit it. Guess what? It does not have the capability of inhibiting or suppressing ACTH production. This will still remain high. In this particular situation, even though there's a tumor, you have the ability to suppress this puppy. And so it will suppress the pituitary tumor. And the ACTH levels will drop. If the ACTH levels drop in these particular situations, then what happens, my friends, to the cortisol levels? In this particular scenario, the cortisol levels will do what for the pituitary? For this one, it'll drop. And this one, it'll still remain high. And that's because the dexamethasone suppressed the pituitary tumor, but it could not suppress the ectopic site. And so in this situation, if ACTH levels are low and the cortisol is low, it's a pituitary tumor. If the ACTH levels remain high and the cortisol remains high, it is an ectopic site likely. And that's the interesting thing that we can do there. Now, there is another alternative. So let's say that you can't do the dexamethasone suppression test, the 8 milligram test. We have another option of being able to help us. So it's just basically an alternative to what we just did. What we can do is we can give another drug. We can give them an injection of called corticotropin releasing hormone. That should sound familiar. That was from the hypothalamus. It makes something called CRH, which tells the pituitary to make something called ACTH. Right? Okay. I remember that. And if you have a pituitary tumor, that would be for the one situation. And if you have a tumor here in the lung, that would be the other situation. Okay. Whenever you give this CRH, you increase their CRH levels. And this does two particular things. One is, whenever you have this pituitary tumor, here's what I want you to think about. Here's the pituitary tumor. I'm just zooming in on it. Guess what happens to the CRH receptors? Look at this. These are all CRH receptors. There's lots of them, right? So in a pituitary tumor, so if this is the pituitary tumor, it has tons of CRH receptors. So it is super hyper responsive to the CRH. So if CRH binds to this pituitary tumor cells, it will get a massive increase in ACTH. For this small cell lung cancer, it doesn't have many CRH receptors. So if you look at this guy, here's your actual small cell lung cancer. Guess how many CRH receptors are present on this? Just for the heck of it, just to be funny. I'm gonna put 1, okay? So you give them all this CRH, and guess what? All right, cool, I got one little site to act on. The ACTH levels for this puppy here will be low. Okay, it's not going to really respond. Or in this case, you would actually, I shouldn't say low because they're still going to be producing ACTH because of the tumor, but it's just not going to be as high as this one here. Okay, so this is still going to be producing ACTH because it's the tumor that has the ability, but if we wanted CRH to help it to produce more, it wouldn't be able to. It wouldn't be able to increase the amount of ACTH production. But in this situation, you give CRH to the patient with a pituitary tumor, they'll pump ACTH like it's going out of style. So they'll have a massive increase, while the one with the ectopic site, it'll still have its normal increase. It won't have any increase in its normal baseline level. So in this particular situation, here's for the pituitary tumor, here's for the ectopic site. What's the end result here with the cortisol? So if you think about it here, if I give CRH to the pituitary tumor, it has tons of site to bind, it'll pump up the ACTH levels like crazy, and the cortisol levels will shoot through the roof. In a patient who has an ectopic site, they'll actually, again, have the ability to bind some of the CRH, but nothing crazy. So they will have a small increase in their ACTH, but it won't be a massive increase in cortisol. So if you see a massive increase in the cortisol and an associated massive increase in ACTH, what will that make you think of? A pituitary tumor. If you see not a big jump in their ACTH and not a big jump in their cortisol levels, that should make you think of a ectopic site. Okay, so this will be pituitary, and this will be ectopic site. I find the dexamethasone suppression test to be a little bit more kind of easy and cleaner though. But this is an alternative, my friends. Okay, so at this point, we screened them, we found that they have Cushing's. We then said, I don't know which type. I don't know if it's secondary or if it's primary. I don't know if it's Cushing syndrome or Cushing's disease. I did the ACTH level. ACTH level is high, then we know it's probably a secondary or disease problem. If it's low and the cortisol is high, it's probably an adrenal problem. If I then want to figure out if it's secondary or ectopic, then I do a high-dose dexamethasone suppression test. And if it suppresses the cortisol production, it's then what? In this particular situation, it's a pituitary tumor. If it doesn't suppress, it's an ectopic site. An alternative is I could do the CRH test. If I give CRH, it should hyperstimulate the pituitary gland. ACTH levels should go up and cortisol levels should shoot up. That would confirm a pituitary problem. If from there, I've said, okay, I have a very strong indication that since the cortisol levels were high and the ACTH levels were low, and we went through all the other tests, I think it's potentially an adrenal tumor. What would I do? Get an adrenal CT or an MRI. I'm going to go a little bit out of order here for a second, but I'm just going to try to make sense of it. An adrenal CT or an MRI, and that'll show me, do I have an adenoma? Do I have a carcinoma? Some type of mass there in the in the adrenal cortex? What would that look like if I showed you an image? So if I had a patient with positive screening test, ACTH levels are low, I get an adrenal CT and MRI, find the tumor, boom, adenoma or carcinoma possibly. Next thing is, if I have a screening test, cortisol levels are high, and then we also get ACTH levels which are high, I'm like, okay, I don't know which one it is. Is it pituitary or is it an ectopic site? I do the high-dose dexamethasone suppression test, and it suppresses the ACTH levels, and it suppresses the cortisol levels. Ooh, that's pituitary. Let's say I just double check. I do the CRH test. I do the CRH test, and again, ACTH levels shoot up, cortisol levels shoot up. Ooh, that's the pituitary because it has hyper-receptiveness to CRH. Then what would I do? Get a pituitary MRI and find the pituitary adenoma. So I get a pituitary MRI, and that would show me the pituitary adenoma. Screening test, cortisol levels are high. I get the ACTH level, it's high. I know it's secondary, I don't know which one, pituitary or ectopic. I do the high-dose dexamethasone suppression test. It doesn't suppress the ACTH levels, it doesn't suppress the cortisol levels, so they remain high. That would support ectopic. I do the CRH stim test. It doesn't actually produce an appropriate increase in ACTH and cortisol levels. That would support a ectopic site. I want to find out where is the ectopic site. The most common is the lungs, small cell lung cancer. But don't miss any other possible tumors like islet cell tumors or renal cell carcinoma. So scan the chest, abdomen, and pelvis. So we would do a CT of the chest, abdomen, and pelvis and find our small cell lung cancer, our renal cell carcinoma, or even our pancreatic islet cell tumor, or many other tumors. But you're looking for a site of ectopic ACTH production, usually a tumor for a paraneoplastic syndrome. So again, that would give us our entire diagnostic approach on how to be able to determine if a patient has Cushing syndrome versus Cushing's disease. Now the last thing is, I didn't want to have anything to draw because it's actually very simple. If you think about treating these patients, it's actually probably one of the easiest treatments that you can imagine. If they have a pituitary tumor, what could you do? Resect it. So do a transphenoidal resection. That'd be the first thing, okay? Second thing, they have an adrenal tumor. If they have an adrenal tumor, things that we can do is we can continue to suppress the cortisol production, and so we can give them something called ketoconazole, but ultimately we could also do an adrenalectomy. The third thing is, if you have a patient who has some type of like ectopic production, again, you have to go and potentially do like chemoradiation or surgical resection, but in the interim until you do that, you can consider ketoconazole to suppress the cortisol production. And the last one, the fourth reason, is if it's due to them taking steroids, so they're taking chronic steroids, taper their steroid dose down, okay? So those are the 4 ways that you would treat them. Cut the pituitary tumor, cut the adrenal tumor, cut out or chemoradiation for whatever tumor is that's causing ectopic ACTH production. In the interim, suppress cortisol production for these 2 with ketoconazole, and if it's due to chronic steroid use, you just taper the steroid dosage. Engineers, we covered this video in a lot of detail. I hope it made sense. I hope that you guys enjoyed it, and as always, until next time.